So the case we presented was a patient that had an EGFR mutation, L858R, and also a TP53. And TP53 has been associated with resistance to osimertinib, but more aggressive disease. So we discussed that this patient should have been considered for an intensification strategy. At the time of progression on osimertinib, the patient also had asymptomatic brain metastases. So there's a lot of differences in terms of the activity of some of these newer drugs in the brain. And as we have young people that we want to avoid doing radiation to the brain, really selecting treatments that have activity in the brain like amivantamab, lazertinib are really important. We also talked a lot about toxicity, especially with amivantamab and lazertinib, where patients can experience more skin toxicity, infusion-related reactions. But we did talk that as we're treating more patients in practice, we're getting better about managing those side effects with pre-medications, very aggressive skin care, and then those patients are able to stay on treatment, and if they require dose reductions, they're still responding. It's really been wonderful to be here and present a case from our practice that we have difficulty with, and really talk to experts that have been part of those trials from the beginning, and really get input from different in the experience of the group in terms of like how they manage toxicities and what they have seen and things that they work. For example, one of the investigators told us that when patients had infusion reactions, he would send the patients home, and then in the next day they had less of that. So I think all this kind of knowledge that you get from being in a big group with multidisciplinary specialists and experts on the field really helps us make better decisions for our patients.